Okay, so Sharif, can you share? Let me first share my presentation. Okay. Okay, good evening again, and to all our participants in the Uro-Oncology certification course. We are into module 6 now, and in module 6, we are talking about organ-confined prostate cancer. And we are very fortunate to have some of the leading experts in prostate cancer giving us a talk. And what we are going to do today is talk about screening and genetics of prostate cancer. A talk will be done by Professor Pankaj Maheshwari. He is a consultant urologist and head of the department in Mumbai, India. This will be followed by another talk was supposed to be given by Badr Mia, but unfortunately, because we had a change of date due to the Eid holidays, some of our speakers are not present in person. This will be followed by another talk on active surveillance and watchful waiting by Hashim Ahmed. And the last talk of the day, of the evening, will be by Professor Jean de la Rosette, the president of the SIU. So just to put face to these names, Dr. Maheshwari is the head of the department, Fortis Hospital in Mumbai, India. A very keen teacher, very keen learner. He is been active member of our conceptual base course as well as the certification course. This is Professor Jean de la Rosette. He is the president of the Société Internationale de Urologie. Again, professor of urology in Amsterdam and professor of urology in Medipol University in Istanbul, Turkey. Professor Hashim Ahmed is the youngest department chair in Europe, and he's also currently the professor and head of the department in Imperial College London. Again, a world-renowned figure in prostate cancer, and we're very fortunate to have presentations from all three gentlemen here. Dr. Badr Mia, who is a consultant urologist and a professor in New York and Albany Medical Center in Albany, New York. And this is a landmark paper by Dr. Badr Mia on published in Journal of Urology last year, looking at the two modalities of prostate biopsies, i.e., the transrectal biopsy and the transperineal biopsy. And this is a paper that all of you should read. And if you don't have access to Journal of Urology, you can write on our chat groups and we will make this paper available to you. So with this, I stop here and we go on to the first presentation of this evening, and that is by Dr. Pankaj Maheshwari. And he is going to talk about genetics and screening of prostate cancer.
Good evening, friends. I thank Dr. Hamad for this kind invitation. I have been asked to talk on screening of prostate cancer and genetics of prostate cancer. Actually, I would have loved to join you live for this meeting, but sadly, I'm committed to one more meeting that is happening today in Nasik. Let's begin with screening of prostate cancer. You would agree with me that prostate cancer is the commonest non-cutaneous malignancy in men. The incidence of prostate cancer is very high, and it is higher in patients, high-risk patients like black ancestry, germline mutations, or strong family history. Today, we have excellent options of early prostate cancer, like the increasing use of biomarkers and MP-MRI. We also know that prostate cancer runs into two variants. There could be an age-related indolent prostate cancer, which patient would outlive this disease and would not impact patient's life in any which way. In contrast, there could be another clinically significant cancer, which is likely to progress to metastasis and death during patient's lifetime, if not diagnosed in time or treated in time. So the goal of screening is to identify these types of cancer without increasing the anxiety, overdiagnosis, and side effects from prostate biopsy by diagnosing these indolent cancers. PSA undoubtedly is the first test that was used for screening. Sadly, PSA did not have a very good pooled sensitivity, specificity, or positive predictive value. Hence, shared decision making was very important. It was important to involve the patient in the decision making process, explain him what we are trying to do and what are the implications of PSA screening. And once he agrees, only then do it. Once you diagnose one level which is elevated, it is important to repeat the PSA before you progress to next steps of evaluation. This is more important in our situations where the incidence of chronic prostatitis is very, very high. So why do we need to repeat? It has been shown that once you repeat the PSA within 4 to 8 weeks, there is nearly a 25 to 40% chance that the next PSA value would come into normal range. In the STHML study, 17% patients, when they were evaluated 8 later, had PSA less than 3. And this duration of reassessment would depend on many clinical factors. As a standard, we take 4 as a cutoff for screening. And this 4 is important because 4 is the highest value which was observed between patients who did not have prostate cancer. Is 3 better? There are a lot of studies which have shown that when you lower this PSA, the cancer detection increases and probably the cancer death reduces. So in high-risk patients, probably lowering this level would have an advantage. While lowering, we should know that PSA also rises with age. So as the age goes up, the normal values or the acceptable value of PSA keeps on rising. Now the question will be, when do we start the screening? We know that when the PSA is less than 1.3 at the age of 40 years, the risk of metastasis in the next 15 years is just about 0.5%. Below 50 years, if the PSA is less than 0.7, the risk of metastasis in the next 25 years is much less than 1%. In contrast, most of the deaths which happen because of prostate cancer had a PSA of more than 1.6 when they were between 45 to 49 years of age. This shows that the first screening probably should be done between 40 to 45 years, and this will help us decide when the next screening happens. And this early age is probably more important in high-risk patients. High-risk patient, black ancestry is a high risk because among blacks, the disease not only happens at an early age, but there is increased risk of metastasis. And their disease progression matches the normal population, but approximately 10 years earlier. People who have strong family history, that is one brother or father or more than 2 male members who have prostate cancer, early prostate cancer or aggressive prostate cancer, have a 4-fold higher incidence of disease and also have a higher incidence of having genetic markers positive for the disease. How frequently should we screen? A standard advice would be to screen between 2 to 4 years between the age of 50 to 69 years. Especially if the PSA is more than 2 at the age of 60 years, then over 15 years, the number needed to screen to prevent one death is as low as 23, and number needed to diagnose is as low as 6. So in this subgroup, being more aggressive in screening would be important. In contrast, if PSA is less than 1 between 45 to 75, or PSA is much less than age-specific median without any family history or known germline mutation, then probably we can prolong the interval between screening. Can we stop screening altogether? Yes. If there are no risk factors or if the PSA is less than 3 after the age of 70 years, or in patients who have low life expectancy, probably no further screening after shared decision making would be a good idea. DRE alone is not a screening test. It may add value when PSA is more than 2. PSA velocity should not be given any significance because we know that PSA velocity increases more in infections than in malignancies. Percentage-free PSA is a very, very interesting test. It is extremely low in patients with high-risk disease. So if we take a cutoff of 25%, then we would be able to diagnose 95% of significant cancers, and we would be able to avoid 1 in 5 unnecessary biopsies. It definitely helps differentiate between BPH and cancer in gray zone PSA between 4 to 10. PSA density, though, is a very good test to diagnose prostate cancer in patients who have, say, Gleason's or whose MPMRI shows PARETS 3. But It is not a good screening test because it is very difficult to diagnose PSA, determine PSA density, because getting proper prostate size would be very difficult without doing an MRI. PHI, though not available in India and Southeast Asia, takes into consideration pro PSA, free PSA, and total PSA. It is better at detecting cancer on biopsy. It can reduce the need for biopsy in 40% and also help in detecting patients which are likely to progress on active surveillance. 4K score, apart from taking 4 serum biomarkers, also takes into consideration age, DRE, and prior biopsy. With a cut of 9%, we will miss very small percentage of patient, but it will help in early diagnosis, prevent unnecessary biopsy, and again help diagnose aggressive cancers. There are a lot of urinary and tissue biomarkers which are used, and they help in a decision about repeat biopsy and identification of high-grade disease. MPMRI, we know, is used before doing biopsy. Can it be used for screening? Or where do we put MPMRI in a protocol for screening? Whether we do biomarkers first or MRI first is one burning question which needs an answer. So there would be two ways of doing it. You do PSA, MRI, then biomarkers and biopsy, or you do PSA, do biomarkers, identify patients at high risk, then do MRI, and then selectively do biopsy. There are proponents of both these protocols, but I would feel in our situations, we would first do a PSA, MRI, get a biopsy done, and then only in high-risk patients or patients where it is needed, we would do biomarkers, because biomarkers probably are more expensive in our situations. Screening is further helped by many validated risk calculators. A lot of them are available online. And with this, definitely we'll be able to select patients who would benefit by screening, and where we would be able to really diagnose these patients early and treat them correctly. Coming to the second part of my talk, let's discuss genomics. Before going to genomics, we need to understand that our body has more than 30 trillion cells which are continuously undergoing replication at different rates in different tissues. During this rapid phase of replication, it is possible that some mutations creep in, some defects creep in. A lot of these defects are without any significance and they are called as passenger mutations, but some mutations may predispose a patient to cancer and disease, and these are called as driver mutations. Whenever such mutations happen, we have two systems of repair of these damaged DNA. One are DNA repair genes, and second is the PARP system. Whenever there is a mutation of these DNA repair genes, then the risk of having aggressive cancer and cancers which do not respond well to hormone therapy will be much higher. Before proceeding further, we should also understand the difference between genetics, genome, and genomics. Genetics is a very traditional study where an individual gene was matched to a particular disease, and the correlation between the gene and its inheritance pattern was studied. Genome is when we look at the entire set of genes in an organism, and genomics is the complex relationship between multiple genes and the environment and how it impacts cancer and other diseases. The interest in genetics has been rising. Multiple studies in medical literature and multiple articles in lay literature has increased the interest of even general public in genetics of cancers. And this interest was dramatically fueled on 13 May 2013 when Angelina decided to undergo bilateral mastectomy because she was strongly positive for BRCA inherited gene defect. A month later, Supreme Court of United States said that DNA cannot be patented, and any research that happens on the genetic field is for use for general public. Over 4 years, from a time when prostate cancer and BRCA were discussed only in familial cancers, in 2020, NCCN said that germline testing should be recommended based on risk of the patient. And this happened because of wonderful studies which were published. One of them is by Pritchard in NEJM, where over 100 patients with cancer prostate were analyzed and the various genetic mutations were studied in them. It was found that germline and DNA repair alterations happened more often in metastatic prostate cancer, in CRPC, more often in locally advanced and high-grade disease, and in patients who had a family history of cancer and prostate cancer. So all patients with prostate cancer, we should consider genetic testing. With extensive advent of genetic testing, the pathology has moved from gross to histopathology to going into the depths of nucleus, chromosome, and now DNA. Again, we should know that all cancers are genetic. What I mean is the normal replication that happens, there are some mutations which creep in, and when the mutation burden becomes high, the tissues either stop getting destroyed or are created at a very rapid rate, and hence malignant growth happens. But all cancers are not hereditary because these mutations more often are not genetically transmitted to the next generation. Here we should differentiate between familial and hereditary cancers. So familial cancers are cancers where there is some clustering of cancer happens, which could be because of a gene which has not been identified, or more often because of environmental causes. If you can identify a pathogenic gene in these families, then these cancers would be called as hereditary cancers, as which happen in more than 60% patients of hereditary cancers, which is because of HOXB13 gene mutation. Most cancers, as we know, are sporadic because exact cause in them is not known. So familial, there is simple clustering. In hereditary, there is Mendelian inheritance. And not only that, the disease can start at a younger age and the risk keeps on increasing with increasing age. And in these patients, there would be a serious need of genetic counselors. There are many hereditary cancer syndromes. HBOC is one of them, where the patient's family has a high risk of breast, ovary, pancreas, prostate, and melanoma. This is related to BRCA1, BRCA2 mutation. Lynch syndrome, other than many other diseases, makes a patient prone to two common urological cancers. One is UTUC and second is prostate cancer. And the classical hereditary cancer, which happens because of HOXB13. Among the mutations could be on the germline and somatic. Germline mutations are mutations which we receive from our parents. So because we receive from our parents, these mutations will be there in all cells all over the body. Not only that, we will transmit them to the next generation. In contrast, somatic mutations are mutations which we acquire. So we are born with normal genes, but because of some exposure either to UV light, radiation, drugs, smoking, or our lifestyle changes, we create some non-inheritable mutations which are called as somatic mutations. So they would cause us disease, but they would not be transmitted to the next generation. So germline mutations are inherited, and if we want to diagnose them, we need to check blood or saliva. Somatic mutations are non-heritable, and they would be found only in the tissue biopsy samples. The common germline mutations are BRCA1, BRCA2, though they can also be somatic mutations. These are DNA damage genes, and once there is a defect in them, the lifetime risk of cancer increases. The lifetime risk of high aggressive cancer is dramatically increases. Not only that, the person becomes more prone to other hereditary cancers. And once we diagnose them, and if we detect them, probably we can help new line of treatment by PARP inhibitors. These mutations will also help us differentiate between lethal and indolent cancers. So if I want to keep a patient on active surveillance, and if these mutations are positive, probably this would not be the right patient to be kept on active surveillance. Do they relate with histopathology? Yes. Whenever there is an intraductal histopathology, the risk of having genetic mutations is very high, as high as 40%. So if your histopathology report comes as intraductal, probably it would be one more indication for a genetic counseling. Somatic mutations could happen in a single strand of DNA or two strands of DNA. Single strand DNA happens more often because of mismatch during the repair. These would be treated by checkpoint inhibitors. Nucleotides can get excised because of UV radiation. Base excision is the commonest way this happens. Again, they impact the PARP pathway and can be treated by PARP inhibitors. Double strand, homologous or non-homologous are the common ways. Again, the common reason is ionizing radiation. And once there are defect in BRCA1, BRCA2 ATM, then treatment of them is possible, and they make the patient more prone to high-risk disease. Let's understand PARP biology. As we have said, DNA repair happens by two means. One is by the DNA repair genes, and second is by the PARP mechanism. Once there is a single strand defect, the PARP comes at this place and then recruits various enzymes for this repair. If there are PARP inhibitors there, then PARP would not come for this repair of single strand. By forking, the single strand may become double strand, and that would cause destruction of the cells. So how do PARP inhibitors work, and why do they work only in patients with homologous recombination repair defects? Because when the HRR mutation is not there, that is one more pathway for repair of the gene. So by giving PARP inhibitors, that pathway continues and hence there is no cell destruction. But if that pathway is defective and we also block the PARP by giving PARP inhibitors, that which something which happens in BRC mutated cells, then single strand defect will become double strand and lead to cell death. How do checkpoint inhibitors work? We know that cancer cells get destroyed by T cells. Cancer cells, to protect themselves, express a PDL1 ligand. This PDL1 ligand will attach to the PD1 of the T cell and neutralize the T cells. So two things can be done. We could use immune checkpoint inhibitors like pembrolizumab, which blocks the PDL1 so it cannot neutralize the T cell, or we could have antibodies like atezolizumab or avelumab, which would go and block the PD1 receptors, again preventing from the cancer cell from neutralizing the T cells. Polygenetic risk score is again one important thing we should be aware of. There are multiple SNPs, means single nucleotide pleomorphism, that happens in population, which creates a difference in population, like difference in eye color, hair color. When there are more than 140 SNPs identified, which are correlated with prostate cancer. So if we can do a polygenetic risk score of these SNPs, and when multiple of these SNPs are there, then the risk of cancer increases by 33%. So this may help in PSA screening. So if patient has intermediate or high borderline raised PSA, if his PRS score is also high, probably this patient is a patient who needs detailed further evaluation. Coming to how to decide which test to be done. Before doing that, we need to discuss and define what we are looking at. If the question is what is the risk to me and my family, then I need to do germline test. If the question is am I a candidate for new precision therapy, then I need to do both somatic and germline test. I would do this test in patients with strong family history, rapid progression, patients who present with metastatic disease, or whenever I want to consider newer therapeutic targets. So NCCN says that metastatic prostate cancer, especially with intrarectal pathology, high-grade disease, more than one blood relative positive for prostate cancer, breast cancer, ovary, pancreas, or other cancers, these are patients where genetic testing would be very important. So the questions could further be risk assessment, should I do biopsy, risk stratification, should I treat, or pharmacogenomics is should I be more aggressive in treatment by predicting response to the treatment. Let's look at few biomarker tests. My prostate score is a score of messenger RNA genes in which especially TMPRSS gene is identified. This is a biomarker for clinically significant prostate cancer. So if the question is, do I need biopsy? And if my prostate score is high, then definitely the patient needs biopsy. Select MDX detects significant prostate cancer. So if select MDX is negative, there is 98% possibility that the patient doesn't have high-risk prostate cancer. So if the question is, can I avoid biopsy? And if select MDX is negative, we can say probably can avoid biopsy. Other tests like ExoDX prostate intelligence score or confirmed DX score, these look at the halo effect. Means these look at the genetic defects in the cells around the cancer cells. So if your initial biopsy comes negative and you have a high suspicion of disease, and if these tests comes positive, then the possibility of finding disease in a repeat test will be very high. So these will give an answer, do I need a repeat biopsy? I want to answer whether I should give adjuvant treatment to the patient. So I have done radical prostatectomy. Is this patient likely to have biochemical failure? Do a decipher test. This will give me the risk of metastasis over 10 years. And if there is a high decipher score, probably the patient may benefit by giving adjuvant radiotherapy. Oncocyte DX genomic prostate score is a predictor of high grade and high stage disease. It is also a predictor for progression of disease. So, if my question is, do I do active surveillance or intervene now, or do I need adjuvant treatment? Then Oncocyte DX score would help me decide to choose between active surveillance and radical prostatectomy. Prolaris is an interesting test. 31 cycle progression genes are checked. It will help me differentiate between patients who need active surveillance and active treatment, and it will also help me predict patients with BCR. This is how the report we get. And if the question is, can I do active surveillance or RP, or do I need adjuvant treatment after RP or RT, then Prolaris would be the way to go. ARV17 is a very interesting gene which, if positive, would predict poor response to treatment by anti-AR agents like abiraterone and enzalutamide. These would be the patients who would benefit by treatment by taxanes. So just to summarize, my prostate score, Silex MDX and ExoDS are used for initial biopsy. PCA3 confirmed DX would decide whether I need a repeat biopsy. Decipher, Oncocyte and Prolaris will help me decide whether I choose active surveillance or active treatment and whether I need adjuvant therapy. Just let's look at the flowchart. I do a pre-SA screening, PSA is elevated. Do I do a biopsy? Get my prostate score, select MDX score. If low suspicion, monitor. If high suspicion, go ahead with biopsy. Biopsy comes negative, but my suspicion is high. Do a confirm MDX or PCA3. If the report comes high suspicion, then do a rebiopsy. Once biopsy is positive, do Oncocyte DX or Prolaris. If the score is low, patient can be kept on active surveillance. Otherwise, we go towards active treatment. Once active treatment is done, Decipher and Prolaris will help me decide whether this patient needs adjuvant treatment. And once the patient lands in CRPC, then ARV7 status or DNA repair gene mutations will help me choose proper drug treatment for this patient. The use of these tests is on a rise, though at this time they may turn out to be more expensive, but they may have positive economic impact and reduction in healthcare cost by reducing biopsies and reducing unnecessary treatments. Whenever we do germline mutation testing, we could get three types of results. Pathogenic definitely needs follow-up, benign can be released and no follow-up needed, or unknown significance, where we are yet not sure what the significance of these tests is. These patients would be kept on follow-up and would need to be followed as we would follow a pathogenic. What tissue to look for somatic gene mutations? Fresh tumor metastatic biopsy is probably the best. If not, then ctDNA or otherwise stored tissue or germline only by blood and saliva. So overall, our understanding of germline testing for PSA is increasing as it is now at a critical stage. DNA repair mutations are easy to do and they play a very important role in our treatment decision and treatment. It impacts treatment of not only hormone sensitive, castrate resistant, whether to give PARP inhibitors or if MSI is high, then pembrolizumab. To conclude, all patients with high-grade disease need testing. The most important genes will be BRCA1 and BRCA2. Somatic tumor testing and liquid biopsy by cell-free DNA is on a rise. And whenever you find one of them, then involvement of genetic counselor is important. Finally, the only limitations at this time are high cost and our limited understanding, but surely genetic clinics would be an integral part of our care. I thank you for your patient hearing.
Thank you very much, Pankaj. It is, as usual, a wonderful talk. And I think you have defined some of the difficult concepts for clinicians related to the genetics and these are very exciting developments. Dr. Maheshwari is available on our uro-oncology certification course WhatsApp group. So you can direct all your questions. And this presentation, like all the other presentations in the uro-oncology course, is available on the PAUS Karachi website. And if you have any concerns and if you don't know the address, you can always write to Mr. Sharif Charania and he'll help you. Okay, Sharif, can you unshare this? Okay, let's move on to the next topic, which is biopsy technique, risk stratification, and my job is made easier by the excellent talk in the first part by Pankaj, and I'm going to skip most of the things that he has already discussed. So I'm going to talk about how to risk stratify, how to do the biopsy, which is still the standard of care in patients. So we know that in uro-oncology, there are at least two cancers which are treated without doing a biopsy. One is testicular cancer, and the other one is the renal cancer, which in majority of situation is treated based upon imaging alone. So when MRI for the prostate become clinically available more than 15 years back, there was great enthusiasm of making a diagnosis and planning treatment on MRI alone. However, unfortunately, this enthusiasm was met with some limitations. So we started looking for how we can improve our diagnosis of prostate cancer without doing a biopsy. So we added the PSMA PET scan to the MP-MRI. And this is a study reported in this month. This is a review published in this month's European Urology Oncology, in which the combined PSMA PET and MP-MRI was used, and the author concluded that the combined imaging enhances the diagnostic accuracy for detecting clinically significant prostate cancer. We need to remember that not all prostate cancer are clinically significant and requires treatment or even to be diagnosed. So it helps in better selecting patients for biopsy. The second important advancement is the use of radiomics and artificial intelligence in assisting making a diagnosis based upon the current imaging of choice, which is MRI scan. And this is published in JAMA Network Open, this month's issue, in which Twilt and colleagues have looked at AI-assisted MRI versus unassisted MRI scan. And they have noticed that the suspicion of harboring prostate cancer in MRI scan, which are AI-assisted, improve the radiological diagnosis of these cancers and maybe the future of reading imaging. However, until that time, we need to remember that the 2025 guidelines still say that prostate biopsy is important, and prostate biopsy is either done as a targeted biopsy or it is done as a systematic biopsy. It can be done either a transperineal route, which is recently gaining a lot of attention, or it is done as a transrectal route, which is the traditional way of doing biopsy. In the PREVENT trial, it was seen that if you do a rectal swab, 1 in 4 patients would have a change in the antibiotic choice. So doing the rectal swab or stool culture is important before you decide if you're doing a transrectal sound guide biopsy. Now, the antibiotic stewardship is an important thing. We know that there is a very high incidence of resistance to antibiotics now. So it's important that we practice antibiotic stewardship. And this can be done by doing transperineal biopsies because in most of these situations, you can avoid. One other development in the 2025 guidelines is about risk stratification. And now the intermediate risk is substratified into low intermediate risk and high intermediate risk. So these are the 2025 highlights of the prostate cancer guidelines. You can obviously go through those guidelines in the European Association of Urology website. Now, when is a biopsy indicated? Either it is indicated in the classical pathway where a raised PSA, and if you're losing a threshold of 4 nanograms per ml or any other threshold based upon your local factors. If there is an abnormal DRE, irrespective of a normal imaging or normal PSA, obviously in that situation, you would do a biopsy. Or if the PSA has resulted in performing an MRI scan. And so these are the broadly 3 classical indications of doing the biopsy. Now, there are 2 or 3 tier sequential or conditional pathways. And these 2 or 3 tier conditional pathways include the PSA to MRI and then biopsy, PSA to the risks calculator that Pankaj has mentioned in his presentation, or PSA risk calculators, MRI scan indicating a biopsy. Okay, so classical pathway and conditional pathways, these are the 2 major indication of performing a prostate biopsy at present. Now, what about risk calculators? I'm going to reiterate again what Dr. Maheshwari has talked about. The clinical data, which is age, digital rectal examination finding, PSA values, and prostate volume, etc., which helps in determining the prostate PSA density, are used as risk calculators to indicate biopsy. If you look at the ERSPC cohort, and this is a risk calculator developed from the ERSPC study cohort, this can also be used, this calculator can also be, and I've given the address. You can just click the link and you can open these risk calculators. I'm not going to details, they have been talked about. The other is the PCPT trial data, and that from that cohort, the myprostatecancerrisk.com is another website where you can put those data and you can actually determine your risk of having a prostate cancer and that further clinical workup. Now, remember, there are a few caveats to the use of these risk calculators. These calculators have been developed in a certain population where the inherent or baseline risk of prostate cancer is different from the baseline inherent prostate cancer in your part of the world. So there is a disease prevalence difference, which makes these calculators not as effective as they are in the population that it has been studied. There are a few studies looking at the validation of these risk calculators in the indigenous population. However, these studies are really in the initial stages and we cannot make definite conclusion. So whenever you're using from the Western to our part of the world, beware that they may not work as well as they have in the population that it was originally studied. So another important consideration is using risk stratification to avoid further workup. And further workup these days is an MRI scan and a prostate biopsy. You can, if your PSA level is between 3 and 10 nanograms per ml, there is one thing that you can do is a repeated PSA. If the repeat PSA is on the higher side from the baseline PSA, probably this patient would require biopsy. The PSA density is a very important consideration, a very important point, because we know that the PSA is produced not only by the cancer cells, but the normal prostate as well. However, for 1 gram of the 1 nanogram per ml rise in PSA is different from the prostate volume. So benign tissue is going to produce 10 times less PSA than cancerous tissue. So PSA density is an important parameter to assess whether there is a possibility of cancer. The third thing is the use of the Rotterdam prostate cancer risk calculator. And it is seen through use of this risk calculator that MRI and biopsy can be avoided in 1 in 3 patients. So if you use the Rotterdam prostate cancer risk calculators, you can avoid MRI and biopsy in 1 in 3 patients. So that's a significant. And in the 73 patients in which the Rotterdam calculator did not indicate MRI or biopsy, and they were subsequently imaged and biopsies, they found that 14 patients had cancer, out of which 10 had ISUP grade 1 cancer only, which is as good as not having a cancer, and 4 had ISUP grade 2 cancer. So it is very effective tool in assessing whether you have a significant cancer or not. The other thing is to assess whether clinically significant cancer is present in a group of men who have PSA between 10 and 2 and 20 and 2 and 10 is the use of the PHI, which is the prostate health index, which use various PSA Pro and isoforms. Unfortunately, it's not available in our part of the world. And the 4K test, which is the 4 kallikrein test, which looks at the free PSA, the intact and total PSA, and the kallikrein-like peptidase HK2. Again, this test is not currently available, at least in Asia, in subcontinent. PSA density is again very important. You need to, and to determine the correct PSA density, you need to have good calculation of the prostate volume. And we typically divide PSA densities between less than 0.15, between 0.15 to 0.29, and greater than 0.3. Now, if you look at this chart on the left side of the screen, the PIRADE versus PSA density, you can see that as the PSA density is increasing, the chances of significant cancer, or the PIRADE scale, is also increasing. So in a person with a PSA density of 0.3 or greater, and there is a 97% chance of having a PIRADE 4 or 5 lesion, which we know are aggressive cancer and clinically significant cancer, which require intervention. Coming to the MRI scan, we know that there is excellent negative predictive value for ruling out the presence of clinically significant cancer if you do a multiparametric MRI scan. If the cutoff PIRADE is used as 3 or less, the MRI sensitivity and sensitivity is quite high. However, specificity is still low, and in fact, significantly low. If we use the ISUP grade 2 and greater cancer, there are reports indicating a significant correlation between MRI and the. If we use cutoff of 4 and greater, then the specificity also increases from 43 to 64%. And this is data coming from over nearly 6,000 patients. So MP-MRI, basically using various cutoffs, can be extremely important in making a diagnosis of clinically significant cancer. Still not absolute, but very good, as good as it can be. If we consider only one imaging modality, then probably MP-MRI is perhaps the best. Now, this is an interesting table, and this is from the European Association guideline reported by Schutz and colleague from the British Journal of Urology a few years back. They have looked at the MRI score and PSA density categories in biopsy naive patient to indicate the presence of clinically significant disease. Now, again, reiterating probably the same points that the PSA density correlates very well with the presence of high-grade pyrette disease in patients who have a suspicion of prostate cancer who didn't have a biopsy as yet. So if you look at low pyrette, which is 1 to 2, low, and your PSA density is less than 0.1, there is no need for biopsy. If it is up to 0.5, 0.2, you don't need a biopsy. But if the PSA density is high, although MRI is showing a pyrette 1 to 2 lesion, consider biopsy. For for pyrette 3, again, if your PSA density is low, which is less than 0.1, then you don't need to do biopsy, and consider biopsy and highly consider biopsy as the PSA density keeps on increasing. And for pyrette 4 to 5 lesions on MRI scan, you need to perform the biopsy irrespective of your PSA density. So you need to disregard PSA density at that point in time. Now, coming to the biopsy strategy and approaches, the strategy for biopsy is either systematic biopsy, which means that there is no prior imaging. You sample sites bilaterally from apex to base. You try and go as far posterior and lateral in the peripheral part of the gland, where the chances of having cancer is high. And 12 core is considered as the optimal biopsy technique. So this is very important. If you're doing a targeted biopsy, the targeted biopsy means that you do target a lesion based upon the MRI scan. So these targeted biopsy can be either MR targeted biopsy, which could be cognitive target, which means that you make a mental image of this is where the MRI was showing an abnormal lesion on the base of the prostate laterally, so on the left side, and then you do targeted biopsy from that side. This is cognitive MR targeting. If you do ultrasound MR, while you're doing a biopsy under ultrasound guidance, your MRI scan is fused with the ultrasound, and the ultrasound will guide you where MRI has detected an abnormality. The third type is the direct in-bore guidance. Now, this is a much more sophisticated way of doing biopsy. The advantage of this biopsy is that you don't need to biopsy every part of the gland, and you only do, this technique is not available everywhere. It's a pretty sophisticated technique. You need to have the transrectal MRI scan, and you need to have all those gadgets to do this MRI in-bore guided biopsies. The future trial is a randomized trial which will compare these three techniques to give a definitive result in the next few years. The approaches, as I've said, is either transperineal or transrectal, which is the classical way of doing things. If you look at the various randomized trials, we'll come to know that the clinical significant prostate cancer detection rate is the same in the two biopsy techniques. The PREVENT trial has shown, again, that clinically significant prostate cancer detection is the same in the two. However, if you do a transperineal approach, you would detect 41% compared to 27% anterior tumors. Compared to if you do transrectal biopsy, you will detect more posterior tumors, 44% in transperineal approach and 59% in transrectal approach. So transperineal is better for anterior tumors and transrectal is better for posterior tumors. This is a slight difference between the two. And there are certain other things that we need to. So when your patient is undergoing prostate biopsy, what are the concerns? And the concerns essentially is related to pain during biopsy. This is something that all patients would like to know. Infection rates, this is another very important thing And this is the reason why transperineal biopsy is becoming more prevalent now. And obviously the accuracy of this biopsy technique. We've seen the accuracy is very much the same between the two biopsy techniques, transperineal and transrectal. And we are going to now look at how to alleviate the pain and infection by doing these two biopsies. So now again, if you look at the guidelines, there is talk about doing local anesthesia prior to biopsy. So ultrasound guided periprostatic block is the standard technique for anesthesia before prostate biopsy. Intrarectal installation of local anesthetic cream is inferior to periprostatic block. Something that is used very frequently is installation of gel into the anal canal and doing the transrectal biopsies. It is considered as less effective than the periprostatic block. So the technique of periprostatic block is the patient lying in lithotomy position, 20 ml of local anesthetic, ropivacaine or bupivacaine, and you inject it first subcutaneously in the tissue where in the perineum, and then the periprostatic block is given under ultrasound guidance, which is predominantly the periprostatic nerve complexes, which is close to the seminal vesicles and the apex of the prostate. You can also combine the periprostatic block with the pudendal block. To understand the pudendal block, you need to remember there are three regions of anesthesia during prostate biopsy. The anal rectal region, and we know that there is somatic innervation below the dentate line from the pudendal nerve. The prostate region, which is subserved by the pelvic plexus S2 and 4 nerve roots, and the confluence of these nerve roots in the seminal vesicles and or the apex of the prostate, and you need to block this area while giving the periprostatic block. The third issue is the skin and perineum, particularly for your transperineal biopsies, and the pudendal and the perineal nerves and their branches really subserving this area that need to be blocked with your subcutaneous. So for transrectal approach, the pelvic plexus, the transperineal biopsy, you need to block the branches of the perineal and the pelvic nerves. Now, let's look at the infection rate from the transperineal and transrectal biopsy. 8 randomized controlled trial over 1,500 patients. The transrectal biopsy causes 48 events in over 780 patients, whereas the transperineal biopsy results in 22 events among 800 patients. So the difference between the two is clinically, statistically significant. The systematic review of over 165 studies with 162,000 patients, and the sepsis is 0.1% and 0.9% for transperineal and transrectal. So clearly there is an advantage as far as the sepsis and infections are concerned using a transperineal route compared to a transrectal route. This is a population-based survey from the UK reported in British Journal of Urology in over 70,000 patients 5 years back. They have noted lower readmission rate for sepsis in patients who had a transperineal versus a transrectal biopsy. However, the difference was only from 1 to 1.4% between transperineal and transrectal. The PREVENT trial noted that there is 0% chances of sepsis in transperineal versus 1.4% in transrectal. And this is the PROBE trial reported by Badamia, who should be taking this talk, but unfortunately, because we canceled last week, he's not available this week. So this is published in the Journal of Urology last year. And he noted that composite infection rates were 2.76% between transrectal and transperineal biopsies. So in this particular trial, the PROBE study, prostate cancer trial, they didn't note any difference between the two strategies of transperineal versus transrectal ultrasound guide biopsy. About antibiotic prophylaxis, well, prophylaxis versus no prophylaxis, Castellini has shown that infection rate is 0.1% versus 0.3% and sepsis 0.13% versus 0.09%. So if you use prophylaxis versus you don't use prophylaxis, the infection and sepsis rate is different. Systematic review of 112 individual patient cohort by Bosourakos and colleague reported in European Urology Open 3 years back. And they have noted that 1.35% patients receiving antibiotic prophylaxis infection rate or infective episodes versus 1.22% not receiving. So again, not significant. And this is all for transperineal biopsies. So now I think the evidence is clearly in support of that you can do away with antibiotic prophylaxis if you're doing a transperineal biopsy. The septic complication and infection rate is extremely low with or without antibiotic prophylaxis. So antibiotic stewardship, which means that you very rationally use antibiotics, dictate that transperineal biopsy perhaps has a certain advantages. Now, if you look at the transrectal biopsy and what we can do to reduce the infection rate, the meta-analysis of 11 randomized controlled trial with over 2,000 patients, the use of rectal povidone iodine preparation and prophylactic antibiotics can significantly reduce the infective complications. So if you're doing a transrectal, you need to take do the rectal preparation with povidone iodine, and you do antibiotic prophylaxis. Rectal povidone iodine RCT before or after. I mean, you either do it before biopsy or after biopsy. There is clear advantage of doing it before the biopsy rather than after the biopsy. What about a meta-analysis of 4 RCTs, including 671 patients of rectal preparation by enema before transrectal biopsies? There was no significant difference if you use or don't use enema in terms of infective complication. So what about the antibiotic prophylaxis? Well, we know that fluoroquinolones, there are European Union guide regulations about use of fluoroquines for antibiotic prophylaxis. And so they cannot be used. So cephalosporins or aminoglycosides are used for prophylaxis. You need to give it for at least 1 full day. And if you're doing targeted biopsies, which means that you probably will be doing fewer pinpricks, then it's fine. Augmented prophylaxis, which means combination of 2 or more different classes of antibiotics, is really recommended if you're not doing rectal swabs. A meta-analysis of 3 randomized controlled trial has shown that fosfomycin was superior to fluorochloroquines, where fluoroquinolones are available. So targeted prophylaxis based on rectal swab stool culture is plausible. However, there's no RCTs available at the moment, but doing a rectal swab or a stool culture will tell you to use which antibiotics. And since there is increasing resistance to fluoroquinolones, you can probably avoid that. So this is a flow diagram about how to make a decision from a patient who is symptomatic or asymptomatic, looking at the life expectancy and then deciding a shared decision maker. Initial risk assessment using the tools that we have talked about. If you think it's a low risk, then pre-biopsy MRI scan probably would be indicated. If it is intermediate risk stratification with an MRI followed by risk calculators and maybe biomarkers And if the risk is high, then you do the biopsy. The risk is low, you can maybe consider deferring the biopsy. What are the complications? Well, mortality is reported, although the incidence is now very, very low. Patients who are on aspirin prophylaxis, which is a very common thing in geriatric population, it's not a absolute contraindication, and people do not have to stop aspirin in all cases. Systematic review found favorable infection rate for transperineal compared to transrectal biopsy, with similar rates of hematuria, hematospermia, and urine retention. So complication rate between the two biopsy techniques is basically the same, except that the infection rate is relatively low. However, the meta-analysis of randomized controlled trials found no difference in complication rate between the two approaches. You need more anesthesia for doing a transperineal biopsy compared to a transrectal biopsy. So these are the AUA guidelines that if you're doing biopsy, then preferably it should be for transperineal route. However, if you're doing it transrectal, you need to make sure that you've taken a rectal swab or doing a stool culture, and then antibiotic prophylaxis based upon the culture studies, and always do povidone iodine preparation of the anal canal before you do the biopsy. Now, there are two pathways that we need to understand. The combined pathway is positive MRI. You do systematic and target biopsies. And negative MRI, you only do systemic biopsies. Now, what are the advantages and disadvantages? The advantage is that it maximizes the detection of ISUP grade 2 clinically significant or higher cancer. However, the disadvantage is that the greater detection of ISUP grade 1 cancer, which does not really need to be detected. If you do the MRI pathway biopsy technique, which means that in positive biopsies, you only do MR targeted biopsy, and in negative, you not biopsy the patient, it is seen that in up to 50% of patient, if pyrite threshold of 3 or less is used, you can avoid a biopsy. However, there is a possibility of missing out some clinically significant cancer in this. So, coming to the concluding part of this talk, perilesional biopsy in MRI positive patients. Negative MRIs can do systematic biopsies, and if particularly the PSA density is high, avoid biopsies for pyrite 1 to 3, and with low risk profile because of PSA density, negative digital rectal examination, no family history, and no ISP grade 1 cancer. So what about the repeat biopsy after negative biopsy? Well, you have few scenarios. So if you have a prior negative systematic biopsy and persistent suspicion, clinical suspicion of prostate cancer, what would you do? If the MRI has not been done, you perform an MRI scan. If you have an abnormal MRI and negative targeted biopsy, then you do, and there is a suspicion of cancer, then you there is a significant chances of having a cancer. If on your pathology, you only found atypical small SNR proliferation and high-grade prostatic intraepithelial neoplasia, then these patients have a very low chance of clinically significant prostate cancer. So you probably don't need to do biopsy again. The added value of other biomarkers is still controversial at the moment, and there is no strong data to suggest. The prognostic, coming to the last bit of risk stratification, we know that the EAU risk stratification is based upon the DMECO classification. It is based upon clinical information on tumor extent, PSA, and pathology from systematic biopsies. The NCC guidelines have introduced unfavorable intermediate risk cancers. So intermediate risk cancer is subdivided in the NCCN guideline into low risk and high risk intermediate risk cancers. And this is coming out to be an extremely important, particularly when you are considering active surveillance or watchful waiting for these patients. The Cambridge Prognostic Group is a 5-tier model, and this is what it is. Again, like the NCCN, it also divides intermediate risk into good and bad, and it is probably a better tool than the classical EAU guidelines. This is a patient that I've recently seen. He's known to me, and I've just put his data into the Cambridge Prostate Cancer Risk Calculator. His Gleason score was 3 plus 4, 7. His clinical stage was T2 and MRI scan stage T2. His PSA level was 21. He's 80 years of age, and there is no evidence of metastatic disease. So I put this data on the Cambridge Risk Calculator, and what we have seen is that the recommendation is that it is CPG4, so this patient requires treatment. This is your classical EAU. What is the future? Well, the imaging biomarker biopsy and our magnetic MRI scan targeted biopsies compared to the classical risk classification of DMECO EAU and their comparison. So which is better? Can we add biomarkers into this? This is what the future is, and there are ongoing studies. Hopefully in the next couple of years, we have better answers. Thank you very much for your attention, and I'll unshare my presentation, and we move on to the third presentation of this evening. Which is by Professor Hashim.
My name is Hashim Ahmed. I'm Chair of Urology at Imperial College London. I'd like to thank the faculty and the organisers of this course for inviting me to give this lecture. I'm very sorry I can't be there in person. This was due to the change in dates, and today really wasn't a good time for me to join your session, so apologies for that. I'm going to talk about active surveillance for prostate cancer. I'm a urologist and I have conflicts, both commercial and academic. The Imperial Prostate team, which I lead, run a number of prospective clinical trials, and we cover the whole gambit from screening right through to metastatic prostate cancer. So the background to active surveillance is that we know low and medium risk prostate cancer, which hasn't progressed or metastasized, has a very low risk of progressing and impacting on life expectancy. And this is because there are a lot of men who have the disease during their life, but don't actually suffer the consequences of a shortened life as a result of the cancer. I'll show you data that shows that treatment in these men doesn't often benefit them in terms of survival, but can cause significant side effects. And we know that there is variable uptake in active surveillance. Each country will have low to high rates depending on how strong the counselling is towards active surveillance. Certainly in the UK, if you are diagnosed with Gleason 6 grade group 1 disease, then there's a 90 to 95% chance that you will go on active surveillance. But more men with grade group 2 disease, intermediate risk disease, could go on to surveillance. Active surveillance is a curative intent strategy. So you do not give immediate treatment. You monitor the disease clinically with PSA tests and other tests, which could include imaging and biopsies. And when there are objective signs of the disease changing, which can occur in anywhere between 20 and 50% of cases, depending on who you recruit into active surveillance and how you do your active surveillance and which country you are on. about 20 to 50% will change, but when they change, you don't lose the window of curability in the vast, vast majority of cases, and you can still cure these men or intend to cure these men with radical therapy or other ablative therapies. The big issue is that, and the reason for why active surveillance is prominent in the debate and in practice now, is we know when you are newly diagnosed, the difference between observation and prostatectomy from the PIVOT study was zero in all comers, and there were no particular signals between those two treatment options. And observation in this was a lesser form of the current modern active surveillance. So observation was closer to watchful waiting, which monitors the disease, monitors the man for symptoms, and then gives ADT and symptomatic relief, but doesn't intend to give curative treatment at the first sign of trouble. And so active surveillance is much more towards a curative intent strategy. Nonetheless, the difference between prostatectomy and observation, which is a lesser form of active surveillance, was zero in this study over a 15-year period for all-cause and cancer-specific mortality. The PROTECT three-way randomized controlled trial randomized newly diagnosed men who were screened with PSA tests, so diagnosed with much earlier risk disease and a lot more low-risk cancers in this group, and randomized them between surgery, prostatectomy, radiotherapy, and active monitoring. And again, this form of active monitoring was a lesser form of surveillance, but nonetheless, they showed no difference in cancer-specific survival between those three arms. However, they did show that those men who are on active monitoring had a higher chance of disease progression, particularly towards metastases. And so a lot of them were and did end up getting treated, almost 40 to 50%. And so this showed active monitoring or active surveillance was safe from a survival perspective, but there were nuances that we needed to deal with. That would be fine, and you could argue maybe there is a benefit, and you could take the SBCG trial, which randomized between watchful waiting and prostatectomy for quite high-risk disease and showed a 5% mortality benefit, and therefore argue that you could treat everybody. But the problem is, when you treat, even if there is a small benefit, the side effects are quite significant. And so therefore the therapeutic ratio of treating everybody is really inappropriate because of these high rates of genitourinary and rectal toxicity. So the advantages of active surveillance are that you avoid the side effects of immediate surgery or radiotherapy, and even if you're suitable for focal therapy, that does carry some side effects, and it would be better to be on surveillance than to have any treatment. And we know that as long as you are monitored carefully, you don't compromise your life expectancy from a cancer perspective. The disadvantages are that there is a burden of tests on individuals and healthcare systems. Men do find it anxiety-provoking, and about 10 to 15% of men on active surveillance, in the literature at least, switch to active treatment even when there aren't any signs of progression. There can be poor compliance to tests, especially regular biopsies, which I think we're moving away from. And this, like I said, the switch to radical treatment due to anxiety or because patients just don't want to have these regular tests can be quite substantial. Active surveillance, as currently done, if you do rectal examinations and regular PSAs, we think the detection of progression is not great. And there is, from PROTECT, a potential for higher rate of metastases. The problem with those last two disadvantages are that they are based on data where patients were recruited on the basis of a transrectal systematic biopsy. And that biopsy is random, and we know it's highly inaccurate. about 50% sensitive to grade group 2 or higher disease. And therefore, if your risk attribution at baseline is poor, then when you go on active surveillance and don't have some confirmation that you really are low risk or low burden, medium risk, then we could be missing something quite significant as a result of trust biopsy, which then progresses and might even metastasize if we don't recognize it. So these days with MRI scans done before biopsy in the vast majority of people, or even if they don't have a pre-biopsy MRI, they have a confirmatory MRI and biopsy after diagnosis in the first year, that detection of progression might be better with PSA, might be better with DRE or subsequent biopsies. And certainly the rate of metastases in modern active surveillance series is very low. It's less than 1%. The problem is we don't really know how to do surveillance, and everybody varies. So everybody uses a combination of PSA and rectal examinations, although people are moving away from rectal examinations now because a finger's not going to be that great in picking up progression. And there are various advice about whether to do an MRI and the timing of those, and whether to do a regular biopsy or not to do a regular biopsy. And so the literature is quite confused in terms of the guidelines supporting clinical practice. So how do we move forward from here? There are now a number of studies showing that if you can see a tumor on MRI, be it grade group 1 or 2, that tumor has a higher chance of progressing. And therefore, that tumor doesn't necessarily need to be immediately treated, but probably should be monitored a little bit more carefully, a bit more closely. And so this study showed that tumor visibility on MRI is a net result of many genes associated with proliferation, inflammation, and regulation transcription, and that visible lesions harbor a more aggressive phenotype compared to non-visible ones. And this is supported by clinical data now, which are retrospective, so we do need some prospective data in this field. This is from the UCLH group by Caroline Moore, showing that the risk of switching to treatment or death is much higher if there is a visible Gleason 3+4 cancer, and non-visible 3+4s seem to behave in the same way as visible 3+3. And that's the same as time to prostate cancer treatment. This is the GAP3 Movember collaboration from a number of institutions internationally, and again showing that visibility on MRI is a significant predictor of whether those men will progress and require treatment in future. And we've known for a long time that Gleason 3+4 grade group 2 confers a higher risk to patients. And this is just one study, there's lots of others, which have shown that grade group 2 or higher if they're on surveillance has a higher risk of progression. So this is an MRI scan. You're all used to seeing MRI scans now, and you can see a lesion which is very small, and it was verified as a 3+4, 3 or 4 millimeters in that area, and that man's been on surveillance, and he's had a repeat scan every 2 years. We don't know whether it should be every 2 years or every year, or maybe even less frequent, and had regular PSA tests every 6 months as well. PSA tests have been fairly stable, and then 4 years later, the lesion showed some sign of change. And so if you go back, you can see that there's been a change in that lesion. Maybe it's grown by 2 or 3 millimeters, but really very subtle. And this obviously needs to be verified on a repeat biopsy, because sometimes you can get inter-test variability. And so this may be a way forward with active surveillance. And the literature on the role of MRI in active surveillance, again, is pretty strong, although the vast majority is retrospective with one or two prospective randomized trials, which haven't really given us that much certainty on the role of MRI. And we can see that the pooled sensitivities and specificities seem to be higher than PSA and DRE, certainly. The negative predictive values can be also quite high. So if you don't see a progression, then the chance of there being progression is quite low. And the data also confirms that visible disease or intermediate risk disease has a higher rate of progression. And the precise reporting system has been developed by the ESUR and wider colleagues to provide an objective, validated system to report on the presence or absence of change on MRI. So to conclude, we need a way forward. So we have started a £2.7 million funded study by the UK government, of which I'm CI, and we are going to look at men who get diagnosed with grade group 1 or grade group 2 disease who choose active surveillance, and they will be randomized between standard of care in the UK, which is regular PSA tests, an optional DRE if the clinician wants to do it, and when there are signs of progression based on PSA doubling times, you do an MRI and biopsy. And we think that might actually be good enough because you have a very accurate diagnosis at baseline, so you know what you're dealing with using an MRI and targeted and systematic biopsies, and therefore PSA actually might be a reasonably good predictor of progression. The intervention arm will be, in addition to standard care, regular MRI scans. So can we detect progression earlier than we would do otherwise, and detect more of those men who might be progressing compared to standard of care? And if these men are diagnosed with grade group 2 or have a visible lesion, they will have a yearly MRI scan for 5 years. And if they have non-visible disease and grade group 1 disease, they will have an MRI scan at 1 year and then 2 years thereafter. And only if there is sign of progression on MRI will a biopsy be advocated. The other trigger for a repeat biopsy would be a PSA change, even in the absence of an MRI change. So if your PSA doubling time is starting to get worrying, then a biopsy would be required to pick up some of the false negatives that MRI might be throwing up. So this is going to provide really good evidence on how best to do surveillance. So in conclusion, active surveillance for men with Gleason 6, grade group 1 prostate cancer is the optimal approach, and this is what should be recommended. MRI before biopsy, or if not possible to do this, then within a year is important to ensure accurate risk attribution up front. So you want to be sure what you are surveying before you go on to long-term active surveillance, because you could be missing something really important. Active surveillance for Gleason 3+4 grade group 2 disease is also safe, especially if you apply an upper limit for percentage pattern 4 of around 20%, then it's safe, and especially the case if it's not visible on MRI and you found it on systematic biopsies only. Active surveillance protocols are heterogeneous and therefore can cause confusion to men and clinicians because people start to make things up, and we do need to find ways to standardize protocols using prospective data rather than consensus or expert opinion or retrospective data. Thank you very much, and all the best for the rest of the day.
Thank you very much, Professor Ahmed. I think the current concepts about active surveillance is very clearly indicated in your presentation. Since we are running late, we would really jump onto the last presentation of this evening, and this will be by Professor Jean de la Rosette, the president of SIU, and he's going to talk about another very important issue, about imaging and technologies in the management of prostate cancer. So, Professor Jean de la Rosette.
Greetings to all my friends in Pakistan. I really feel privileged to be joining you for your wonderful webinars. I've been following it closely and see with great enthusiasm where all your colleagues participate actively and get the certificates. My name is Jean de la Rosette. I'm the president of the SIU, Société Internationale d'Urologie, and I have been invited to talk about imaging and technologies for prostate carcinoma. I'm working in Istanbul Medical University, wonderful place. You are most welcome to visit us. And at the moment, I'm in Cadiz, participating in the annual meeting of the Spanish urologist. Because of this, I cannot take part this Saturday live. I wished I could have taken part live, but I got the privilege to record this session. So let's talk in the next half hour about imaging and technologies for prostate cancer. And I do not pretend to be able to cover all because it's a vast area, but I'm going to touch some of these that I think that are important to all of us. Looking at prostate awareness. In the past, everything was guided by digital rectal examination and by PSA. PSA for checkup. Looking at this, an old graph, it shows that there seems to be a kind of epidemic of prostate cancer. And the question is, what is causing this epidemic? Are we really seeing and having more cancers that deserve to be treated? Or is it just caused by PSA testing? Could be. We got a test, we test more, we find more. The answer to that could be very simply no. And why no? Because it may be caused by the way we take our biopsies. And as you can see here, in the past, we have been taking most of the time systemic biopsies with all kinds of different schedules. Was it smart or not? Well, that was the way we could do it in the past. We had no other possibilities or opportunities. Then when we looked at PSA in general as a test, we thought it was also reducing mortality. As you can see here, the relative risk reduction because of PSA testing has been significant, but the absolute risk reduction has been close to 0.5%. But interestingly, the incidence of diagnosing cancers that do not need treatment is as much as 10 times more than before the PSA era. So maybe PSA for testing and the biopsies that we're doing in a systematic way is not the best way to proceed. So the key to open up the door to reduce prostate cancer mortality without causing too much harm is reducing overdiagnosis. Overdiagnosis, overtreatment, they are some way close to each other. And the key to open that door to perform better is obviously imaging. So if we perform imaging, starting with an ultrasound of the prostate, the question is always, does this patient have a carcinoma? So the indication for ultrasound to diagnose prostate carcinoma has shifted to a complete different way at looking at prostates. And as you can see here, ultrasound imaging was often very ambiguous. You might see a tumor, but you might not see a tumor. First, it was considered hyperdense, then it was hypodense. So looking at all this, obviously, imaging in the standard way it's not the best to proceed. But now we've got MRI in addition to ultrasound. We've got CT, nuclear, and PET imaging. So all of these give additional information to make the final diagnosis of whether we find a significant cancer, yes or not. And you can see here the different imaging modalities that are available to help us to select patients for the best treatment. One of the studies here, which is the PROMISE study, was a milestone study published just over 8 years ago. And you can see that in a significant group of patients with the PSA between 3 and 15, multiparametric guided biopsies plus template mapping biopsies were taken without targeted biopsies. And you can see that the conclusion from that work was, obviously by including MRI in all this, that biopsies could be avoided in over 1/4 of males. We also looked at the aggressiveness of the tumor, which was upscaled, but trust biopsies may have missed half of all these. So MRI came in the picture, and especially studies like these have positioned it very strongly. And also, if we talk about prostate carcinoma, is it a clinical significant cancer? That was the new wording, because not every tumor is one that deserves a treatment. So the conclusion from all this is if MRI and targeted biopsies are added to systemic biopsies, the overdiagnosis will increase. So just taking systematic biopsies, maybe only MRI and targeted biopsies should be taken to diagnose clinically significant tumors. So again, if you use MRI, we also should use this in a wise way. And MRI and MRI and MRI and reader and reader and reader, it's not the same in every place. How are we going to avoid this? This whole discussion, how should you be trained? How many MRIs should you read? How good are you at it? And obviously, not everybody has the same quality as a reader for MRI. So touching on another topic is, where do we come in to avoid this human error or limitation? And the magical word is always artificial intelligence. Now, MRI reading, radiology, obviously is the best specialty that can help us to make use and benefit from artificial intelligence. And you can see here that computer systems, with the help of a reader to identify, can help us for better prostate segmentation. Once this is done, we can go for Pirate's prediction. And always keep in mind, the system needs to be trained. It needs to be trained with a lot of different images where the diagnosis was confirmed about the tumor and the location. And we can do this by learning this from radical prostatectomy specimen, comparing them to MRIs. You can see there is always a specialist involved to look at the images, the reading, and confirm this as a second opinion. What I see and indicate on the MRI, is that truly something which should be considered as Pirates 3, 4, or 5? And then compare this and confirm this by final pathology. Now, if you look at these data here, where in these studies, which were published recently, you can see that the area under the curve, by having this prediction of the location of a tumor, or even the Gleason grade prediction, look very attractive. So this is where artificial intelligence, the machine learning, is performing better than the best reader ever, because there are more details that can be identified by artificial intelligence. So studies are ongoing at the moment. Data are being collected, and actually you just can use at the end reports and compare them to images. So a lot of different programs are available. And you can see here when we are going to apply this in clinical setting, which is at the moment strongly being introduced, you can see that we can identify on one hand non-clinically significant prostate cancer, which is on the left side of the image, and on the right side you can see clinically significant prostate carcinoma. And again, this is published quite recently, so we are not lagging behind, but we are learning with different programs, and we have to select which one we are going to use in the future. And you can see here, again, with algorithms, how we can update these different settings. So looking at the whole workflow, you can see that artificial intelligence is like a spider in a web. It can help us with identification of the lesions and prostate segmentation. It can give a prediction of the pirates. Is this a clinical significant cancer that deserves to be biopsied? It can also predict in the future the Gleason scoring and even predict survival of the patient based on his clinical data. And of course, if there are any anomalies, they can be detected by the system as well, because some people say, how can you differentiate between an infection, prostatitis, or prostate carcinoma? The system is going to help us in this. So in a summary from that, you would say there will be an enhanced accuracy. That's what we need, whatever we're going to treat. Is it watchful waiting? Is it going to be active surveillance? Is it going to be radical prostatectomy, radiation therapy? Anyway, these algorithms can improve the accuracy of detecting and characterizing prostate cancer in MRI images. And I don't even discuss about improvements of further MRI technology. Time efficiency, AI is much faster than any person. It can scan a lot of these. So we do not maybe need a lot of radiologists in the future. So for the radiologists listening, rethink what the future is going to bring for you. We talk about consistency of the analysis, I remember for Gleason scoring, when Gleason himself was looking at 100 slides, and he looked at the intra-observer variability. It consisted in his case as well. One time he was calling this a Gleason 6, a 3 plus 3, and the next time he thought it was a 3 plus 4, So these inconsistencies are going to disappear. You can look at subtle changes, of course, and again, as I said, a human eye may have missed something, but the system will not do this. Then we have improved risk stratification, assessing aggressiveness of the prostate carcinoma, can tell us if it's a T2 or a T3A or a T3B, and it can be integrated AI in the imaging with multiple other data sources, just like genomics and clinical data. So when we look at diagnosis of prostate carcinoma, the era of digital rectal examination is going to disappear. Should we stop doing it? I would say no, but the answer it will be yes. PSA testing, yes, it's going to be there, obviously. And then for imaging, we will move towards MRI imaging, but we will include whatever imaging we're going to use, artificial intelligence. This part is the easy one, because that's the assessment of the patient. Now that he knows that he has a carcinoma, and it's a localized carcinoma, he has to make choices. What is the treatment that he is going to have? So in this, he comes in a kind of roller coaster. And the roller coaster says, well, you should have radical prostatectomy. He's going to Google and says, yeah, I should have radical prostatectomy. But maybe it should be brachytherapy. It's not such an aggressive cancer. Maybe I don't need surgery, not these side effects. Why not brachytherapy? Or radiation therapy in general. You have no very nice stereotactic radiation therapy. Maybe I should have that. Or is it active surveillance? Active surveillance, why not? And then there is this new player, focal therapy. Focal therapy came up about 3 decades ago. And at the moment, there are different modes of action. You can freeze, you can heat, you can irradiate, you can use electric current, and you can use laser to treat a localized prostate carcinoma. Is this new for us? Yes, but it's already going on for many, many years if you look at treatment of breast cancer. We, as urologists, are far behind of what other specialties are already doing. You can see that the first randomized controlled trial was reported in 1985 for breast cancer. This is crazy. But one way or another, we're lacking behind because also the cancer is a little bit different. Because the cancer, prostate carcinoma, is often multifocal. It has satellite lesions. So because of this, we sometimes think that a radical removal is just better. When focal therapy came in the picture, the question is, what is the definition of focal therapy? The precise in situ destruction of a predetermined volume of tissue by the direct application of energy. It's always energy. And what we want to do is to eradicate the aggressive tumor, preserve uninvolved tissue, preserve GU functions, preserve sexual functions, and the oncological outcome should not be inferior. Well, that sounds easy, but it's not. And you can see we had a meeting and a communication on that in 2010, just 25 years ago. And the aims of this is to cure potentially aggressive cancer with minimal side effects. And we should select in this way suitable candidates for this, but also maybe not all focal therapies are suitable for the same patient. We identified in consensus meetings that patients with mild to moderate LUTS are not contraindicated for focal therapy because that was an issue. If a patient has voiding complaints, is he still a candidate for that? For men with smaller size prostates, they are the most suitable candidates. But if they have larger size prostates, it's difficult to reach with focal therapies all the different regions in the prostate. So depending on where the tumor is located, can be done yes or not. If a patient has no erectile function, you shouldn't exclude him. You cannot say, hey, but you're not potent anymore, so why should we treat you with focal therapy? That seems stupid, but this argument is not to be used. We looked at comorbidities, but also what does the patient expect from us? He comes in the morning to the clinic, leaves in the afternoon, tumor is cured. It's still a surgical intervention. And then it should also be involved that if it fails, what will be the next step? What should we do? Should we go for salvage therapy? And of course, you want to know what are the possible complications. So in this, looking at focal therapy, it's somewhere sandwiched in between active surveillance and radical treatment. But it aims to have the same oncological safety. If you look at this, we can go for curative intention, for low risk, intermediate risk, or for disease control, maybe low intermediate risk as well, or for high risk patients. And at present, we have been moving a little bit towards the more intermediate risk patients. We talked already what we're going to treat. And you see here in this radical prostatectomy specimen, a big lesion and a smaller lesion. Maybe the index, the dominant, the most highest Gleason score rated lesion is the smaller one. So we need to know exactly what we're treating. So this is actually what we should know before we treat. We should know this by imaging and of course by biopsies. So the index lesion coming to this for focal therapy is a radiohistological concept. Seen by imaging, confirmed by, but it's only finally confirmed at the final procedure. So if we talk again to clinical significance, and you can see all kind of different locations of a tumor. So what is the best method to identify this? Yes, we come back. Index lesion is to be seen on MRI. And again, coming to this, remember artificial intelligence. We're going to get it automatically in the future when we buy an MRI machine that the software is going to come with it. I also discussed or touched on earlier that we have been moving away a little bit from different concepts, how we could best make the diagnosis. We moved away from template mapping biopsies to multiparametric MRI targeted biopsies. Template mapping biopsies may be, again, overdiagnosis tumors that don't need to be treated. We moved from low to low intermediate risk patients. We moved from Gleason 6 scores. We moved away to include also Gleason 3+4 and 4+3 as index lesion. We moved from T1 to T3 to more localized tumors, T1 to T2. And of course, if we talk about unifocal, we also are now including multifocal lesions. And I will show some of this. From all the energy sources available so far, we see that HIFU is number one in what is being performed or available on a global base. And this was coming from a consensus meeting that we had many years ago. See cryosurgery, laser ablation, brachy, and you see IRE is also coming up to this. IRE was a new kid on the block, obviously. And I want to present a little bit the picture on IRE, presenting on what should be done in focal therapy to confirm that it's a safe treatment, how good it is, and to share the data on functional outcomes and oncological outcomes. So what are the pros and the cons? Let's first look simply at the pros. If we look at IRE, it's a nice needle-based, transperineal needle-based technology. It generates an electric field between a plus and a minus pole. It creates micropores in the cellular membranes and eventually destructs. There can be an increase in temperature, but obviously the idea behind it, it should not raise temperatures within the prostate to secure, not to damage structures that you do not want to destroy. And here you see a transperineal template in place where we are putting needles. We did a phase 1-2 pilot study. We did this in Amsterdam together with colleagues from Athens in 16 patients. And what we did is we had an IRE treatment fully under narcosis. And 4 weeks later, they had a radical prostatectomy. Many patients said, should I do this? But the majority says, yes, I would like to contribute to research. They didn't get any money for this, no compensation, but 4 weeks later, radical prostatectomy. Looking here at the needle configurations on the ultrasound, you could see that we more or less could nicely predict when we put the needles, what would be the volume or the area that we would destroy. So we could learn for the focal ablation with 3 or less electrodes versus a more extended ablation with more than 3 electrodes, what we could cover. And what you can see here in whole mount radical prostatectomy specimen, you can see that we could predict the area that was treated, and within the area there was complete destruction. And the beauty of this all was that we could confirm this on MRI imaging, and on the left side you see contrast enhanced ultrasound imaging. So both of them matched very well. The left on the ultrasound that shows on the black hole, no perfusion. On the MRI imaging, you can see very nice the contour, and you see the radical prostatectomy specimen. I think this is impressive. This is confirmative that when you can target and can predict the area of the lesion, you got a winner. So looking at the other quality of life parameters that we took at pre-IRE, after 1 week, after 4 weeks, you can see that all the functions have been preserved. Of course, in the VAS score, in the first days, there was some discomfort, but overall, after 4 weeks, everything was gone. And that's the beauty of it. It's a minimal invasive treatment without removing an organ at minimal side effects. The next step was to conduct a randomized control trial. And in the randomized control trial, what we wanted to do is a focal treatment versus a more extended treatment. Not a hemiablation, but more extended treatment with patients that had a tumor in one lobe only. We wanted to see how good we could treat those. So for this, we took at that time template mapping biopsies to be sure that on one lobe there was no tumor and the other there was. And of course, we took MRIs. This is the publication that came from this. And we had 5 centers that participating in the study, and we included 108 patients. At the end, randomized 106, and we could analyze 48 and 53 in the different arms. You can see here the ISUP grades, the clinical stage, and the number of cores that were positive. You can see that both groups were equally and well distributed. We could also see that after the treatment, after 6 months, we took again biopsies. This was in the protocol. Is there still tumor, yes or not? And you can see that location of positive cores in the treated area was still present. There was still tumor present in the treated area. Question is, how well can you look at the treated area as such? But out of the treated area, there was also a significant number of positive biopsies. And if you combine this, obviously, we had a treatment failure, where we said, well, we tried to aim at eradicating all cancer. Most probably did, but still there was some satellite tumor on that side that we didn't reach, but also on the other lobe. Because even with the template mapping biopsies, we couldn't collect all of these. So in our conclusion said, well, this is a promising technology with promising oncological control in patients with low to intermediate risk prostate carcinoma. Were we fully happy? Mixed. But in the end of the day, if you perform radical prostatectomies, you also don't achieve 100% oncological safety. So yes, we were happy with this. But could we be happier? Let's look at the cons of this. We looked at the cons and we said, well, okay, assessment with MP, MRI, multiparametric MRI versus template mapping biopsies. We did a sub-analysis on this and just recently published in the British Journal of Urology, where we looked at in the treated area whether there was, what was the sensitivity, specificity, positive and negative predictive value, and the data looked reasonable. They were not excellent, they were reasonable. And you need to be fair. You know, if you offer patients, you need to be able to share the data with them. So we said that multiparametric MRI and template mapping biopsies should be performed to avoid missing residual clinically significant tumor. Again, this is in studies. But if you are outside studies, it's obvious that you need to be practical. You need to follow up the patients with MRI, and if needed, maybe by PSA rise or abnormalities on the MRI, you should take biopsies. Standard biopsies after 3 months, 6 months, 12 months is maybe is not desirable, but it's good for studies to know what you're treating. And then you have to think about the strategies. What are you going to treat? Just, are you considering to treat the whole prostate, ablate the whole prostate as a focal therapy? Or are you just looking at the tumor or the different tumors? Well, with this in mind, one of our colleagues from Paris, Michel Suberville, has been treating a nice cohort of patients with a focal and a hemiablation approach. And we recently submitted that also for publication, and it's now with minor revisions coming back from cancers. And what we learned from this is that patients who had a hemiablation, which are here in green, had a better oncological outcome than with a focal treatment. He also did some patients with a whole ablation, ablating the whole prostate. And he said, no, the morbidity is too high. But the hemiablation came out much better. And he says, this has a 3 times better overall cancer-free survival than focal ablation as such, just for the lesion. And it didn't compromise, this hemiablation, the functional or sexual outcomes. So with this, I would say starting with a pilot study, phase 1-2, starting with a randomized study. We also did a registry. And with these data, it's obvious that you need to properly evaluate any focal ablative treatment like this, and then make a decision. What is the best? And maybe, I think now we move to hemiablation. Maybe we should really consider that to have a better outcome. The last part is focusing on, and what if it fails? What should you do in those cases? What is treatment failure as a definition? Or is it just persistence of tumor? So lesions visible at first image after image-guided focal therapy or biopsies, the question, is this something that was not treated, or is it a new tumor? So most probably, if it's on a short term, it's still persistence of tumor. Is there progression? You can have both type of failures at the same time. And this is a publication related to this. And you can see that the treatment of failure has additional impact on quality of life. And you can have patients who had a treatment but actually are not fit for watchful waiting but need an additional treatment. So can we offer them a salvage radical prostatectomy? And you can see numerous publications are now facing the surface. This is a nice one which was published in 2022 with a big cohort of 365 patients. And you can see there was redo IRE, there was active surveillance, there was salvage radiation therapy, salvage radical prostatectomy, hormonal treatment. Everything is possible. But obviously, it's not one homogeneous approach. You need to tailor this depending on the outcome. Now, one thing that was very strong in this paper, they said, look very well what happened here as well. Because there is a migration in ISUP grading and risk group in about 30% of patients. I mean, upgrading, which means we move from Gleason grading 1, 2, 3 to 1, 2, 3, and 4 and 5. So more higher risk patients. So actually, our biopsies said it was maybe a Gleason 3 plus 4, but at the end it was a 4 plus 4, or even a 4 plus 5. So when you treat patients with focal therapy, you have to keep in mind that you do not always have final pathology. And since you only do a hemiablation, you cannot trust PSA as such, because it's not reliable. When you look at the procedures, it is feasible to do radical prostatectomy as a salvage. But keep in mind again, in a center of excellence, you need to have a lot of experience. Coming to this, positive surgical margins could be found. You could see in a significant number of patients, the margins were positive. So again, focal therapy is attractive, but maybe also has some significant limitations we need to be aware of. And this is not yet the end. It's the end of the beginning or the beginning of the end. No. Looking at the take-home messages is that we have IRE studied very well, maybe one of the best focal therapies that has been best studies on it. It has good functional outcomes at acceptable, and I say acceptable oncological outcomes. We look at multiparametric MRI and biopsies, still has significant limitations. But now I think when we listen to our friends and include artificial intelligence with the software in that, I think that's when we go to make a big gain. Total ablation has better outcomes than hemiablation and focal ablation, but also has an enormous morbidity. So hemiablation maybe should be considered as the best choice in between. Radical prostatectomy as salvage is possible. Outcomes vary widely among centers. That's what came from the publication as well, and it depends on the volume. But last but not least, which is also a minus, is that the significant upgrading from initial diagnosis to definite pathology highlights the need for more accurate stage and selection. And I think with this, I tried to give you a fair summary, what you can expect from all these technologies, focal therapies. That's what the patient wants at the end. Quality of life, preservation, quality of life. And you would keep this at a reasonable risk of oncological safety. With this in mind, I want to thank you for listening to me. I hope it was not too boring. I would have loved to discuss with you in person, and we can do this in person when you come to our annual SAU meeting, which is in October in Edinburgh, October 29 to November 1st. And as SAU president, I look forward, and all my colleagues, to more closely work together with the Pakistani colleagues, the PAUs, and see how you can enrich our society and we can return something to you. Thank you very much. Have a good meeting and see you soon in person. Bye-bye.
Thank you all. The next session on prostate cancer will be on next week. Okay, bye bye, you all.